Anesthetics, Medicine, and Senzyme. Senzyme has given us a grant specifically for the Naguib lecture. Please find time to meet with the corporate representatives who are here in the room and have joined us today and learn about their products and thank them for their support of ISAP. So finally, I want to express my deepest gratitude to Jane, Jane Svinicki has been a long time executive director of ISAP. She's the person who's managed all the essential details for this meeting. She's also managing the tech in the corner and on Zoom and provide and technical support for the speakers. So please join me in thanking Jane, truly the most important person here today. Okay, so it's my pleasure also to moderate session number 1, and I'm going to introduce our first speaker, who is Andre de Wolf. Dr. de Wolf is a professor emeritus of anesthesiology at Northwestern University's Feinberg School of Medicine. He completed his medical school in Belgium, and his clinical anesthesia training was at the University of Pittsburgh. So his career included providing anesthesia for cardiovascular, thoracic, and transplant surgeries. His academic interests are pharmacokinetics of inhaled anesthetics, which will be the topic of his talk today, and the monitoring of respiratory gases. His talk is entitled End-tidal Anesthetic Concentration, Monitoring, Interpretation, and Clinical Applications, based on a comprehensive review that he co-wrote with Jan Hendricks last year. Please join me in welcoming Dr. de Wolf. Oh, and I'll add, if you could hold questions until the end, and I will bring the microphone to the questioners.
Thank you so much for this nice introduction. It is indeed true that Jan Hendricks and I have co-worked on these topics, kinetics of inhaled anesthetics and carriers, for at least 30 years. Although he lives in Belgium, I live in first Pittsburgh and then Chicago. Thanks to the internet, we got it done. Takes time, but we got it done. So I have to recognize what Jan is doing for this presentation. So these slides have been selected and made by myself, and they were approved by Jan Hendricks. And the content is solely my responsibility, and Getinge will sponsor part of my travel expenses. This is what we see on the monitor. This is what end-tidal monitoring means. We have concentrations determined of all the inhaled anesthetics that we use, and this for inspired and expired partial pressure. And it gives us a MAC value of this. This MAC value is sometimes confusing because this MAC value is not the MAC of any of these agents that we express. Is the fraction of MAC that is the sum of all the fractions of MAC of the inhaled anesthetic. So in this case, MAC is not MAC. MAC of an anesthetic is a fixed number. It cannot change over time. MAC. Isn't MAC about immobility? And aren't we interested mainly in unconsciousness? Because the triad of anesthesia is unconsciousness and or amnesia, immobility, and blockage or tempering of hemodynamic responses. So what does the MAC value as it's displayed on a monitor means in terms of unconsciousness? And that's really what I'm going to talk about today. So MAC is defined as minimal alveolar concentration. The definition was provided by Ted Eager and Larry Seidman. It is the steady state alveolar concentration after at least 15-minute steady state that results in immobility in 50% of animals or humans after a noxious stimulus in the absence of any other drug. And that's very important. You cannot co-administer any other drugs if you're going to determine MAC. The only factor that it depends on is age and possibly also some genetic factors, but even that is not very clear. So there's not a whole lot that affects MAC. It's just age and the agent that you're using, of course. So how do we determine the MAC? Well, we have subjects that are exposed, and these are all the dots that you see, subjects that you are exposed to a certain anesthetic concentration. In this case, that's right. And you just make a note of whether the patient under that concentration at steady state moved or didn't move. If the patient didn't move, you add a dot up there. If the patient moved, you have a dot there. If you now do logistic regression analysis, you get the sigmoid curve. And the midpoint of that curve, the median, is MAC, EC50. Now, I said the median, but MAC says minimal alveolar concentration. So that doesn't match. It's clear that the definition as was provided by Eager and Seidman is, in a lot of people's opinion, not correct. It should have been median. So MAC should have been called a median alveolar concentration. Partial pressure should have been used instead of concentration, so that the definition is valid at any height, at any atmospheric pressure. And we should have used end-tidal partial pressure instead of alveolar, because I don't know anybody who can determine alveolar partial pressure of a gas. Can't do it. So you can then create a new definition. MAC is the effective end-tidal partial pressure at steady state that results in 50% probability of the clinical endpoint being attained in a population, or EC50. I think that's a better definition of MAC. Now, MAC has been expanded. It has been used not just for immobility, but also for other purposes, like MAC awake. It's the 50% probability of a patient being awake or not after a verbal command. MAC bar is the blockage of adrenergic response to a noxious stimulus, to a standardized noxious stimulus. And the principles are the same. So we get steep end-tidal response curves with all these three definitions or subsets of MAC. So when we give anesthesia, we are really interested in providing unconsciousness. That's a contract that we make with the patient if we tell them that they are undergoing general anesthesia. It really means that we're telling them that they're going to be unconscious for the procedure. If we allow a patient to be conscious during a general anesthetic, that means that we have kind of failed. Unless there are special circumstances like a wake-up test during a neurosurgical procedure, but I'm not talking about these exceptions. But if we tell a patient that they're going to be under general anesthesia, they expect to be unconscious and not remember anything about it. Adequate anesthesia also includes immobility so that the surgeon can do his or her work. But it doesn't mean that it's as absolute as unconsciousness. Unconsciousness, you want in more than 99.99% of your patients. If you have a failure in 1 out of 1,000, that seems to be somewhat acceptable because that's what it is. There are certain things that do go wrong during the administration of anesthesia. So, but we expect 99.99% success rate. For immobility, the goal is not that high. Small movements by the patient, as long as they don't interfere with the surgical procedure, are okay. If the patient undergoes a foot surgery and they move a little bit with the arm, the orthopedic surgeon will never notice. They don't know. However, you have to make sure that the foot doesn't start to wiggle, of course. But the immobility goal is not as strict as the unconsciousness goal. And the same is actually true for autonomic nervous system control. During intubation and during certain very nociceptive parts of the surgical procedure, we see changes in heart rate and blood pressure. We see that all the time. We cannot expect a railroad track anesthesia record where there are no changes in blood pressure and heart rate. But we want reasonable control from an inhaled anesthetic. And then we have to supplement that with intravenous agents or increasing the anesthetic concentration or whatever you choose to do, as long as the patient is unconscious. So the three MAC concepts result in these three different curves, where you have a curve, a dose response curve, or in this case, a no response curve for unconsciousness, immobility, and blunting of the adrenergic response. And the values are, they're not totally correct for MAC unconscious or blunting of adrenergic response because they are not clearly known. For unconsciousness, it's actually very difficult to determine unconsciousness, and I will talk about that in a minute. And for blunting of adrenergic response, some potent inhaled anesthetics are more potent in suppressing the adrenergic response to nociceptive stimuli than others. So there should be a little bit of a range here instead of a fixed value of 2, depending on the anesthetic that you're using. But still, these curves are pretty steep. So you have a small standard deviation. If you now translate this into what we should achieve clinically, then at 0.7 MAC, we see that there is a 99.99% probability of unconsciousness. At 1.4 MAC, roughly, we have of sevoflurane. We have a 95% probability of immobility, and I'm sorry, this is MAC fraction, and at just over 2 MAC value, we have an 85% probability of blockage of adrenergic response. So these numbers are kind of acceptable in the clinic. These are the goals that we want to achieve. Now, probability unconscious, how do we approach this clinically? And there are a lot of people who use EEG monitors, raw EEG, or the BIS monitor, or other devices based on EEG. And Avedon did a study in 2011, published in 2011, where he looked at the incidence of intraoperative awareness under BIS monitoring or raw EEG monitoring. And the incidence was 0.24%, which is somewhat high, I think, but that's what it was. In the second arm of the study, he kept the patient's Fmac higher than 0.7, and he found an incidence of intraoperative awareness of 0.07. So just looking at the fraction of MAC and using that as your guideline, you have a lower incidence of intraoperative awareness than with using other EEG-based techniques. And this result could even have been better because he achieved the Fmac of more than 0.7%, fraction of 0.7, only in 84% of the patients. If he had used alarms on his anesthesia machine that triggered when the Fmac was less than 0.7, and they increased the anesthetic, it's easy to predict that this number would even have been lower. I think this is an excellent study because it gives us a very good idea on what the fraction of our MAC should be under steady state in order to induce unconsciousness. Unconsciousness, as we see on the left, and in between parentheses, and amnesia. For several years, I thought that, well, unconsciousness is a yes-no phenomenon, or you're conscious or you're unconscious. It's binary. But it has become clear now recently that there are different kinds of unconsciousness. That you can have several reduced states of consciousness or altered states of unconsciousness. And that has been shown very clearly by the isolated forearm techniques, especially Pandit has done several studies on this. And if they isolate a forearm before the paralytic agent is administered, and you give a verbal command to the patient, so squeeze my hand in the unparalyzed arm, you get a positive response to a verbal command in between 5 and 32% of the patients. A wide range, because there are several studies that were done, and the results were very different from study to study. But Dr. Pandik was a visiting professor and a speaker at one of the NAVAT meetings in Belgium that Jan and I organized. And he went to the operating room, and we did an experiment with a forearm isolation technique. And lo and behold, in 2 out of 4 patients, if I remember correctly, the patient responded. The patient had about 1 Mac of inhaled anesthetic on board under steady state. And the patient responded. And I asked, squeeze my hand, and the patient did. And then I said, squeeze my hand 3 times, which required a lot more brain activity by the patient than just squeezing once. And the patient squeezed my hand 3 times. I almost fell on the floor because I was flabbergasted that this was possible. Conditions where I always thought that the patient was totally unconscious gave a very different result here. It's kind of scary. Kind of scary because now we have no handle anymore on how to evaluate the primary goal of general anesthesia, which is the induction of unconsciousness. These patients didn't make any spontaneous movements in their isolated arm. Recall was very uncommon in these patients if they have a positive response. If you try to do that in non-paralyzed patients, you had absolutely no response in anybody. So somehow the paralytic state of the body, or the majority part of the body, is required to have this kind of a response. This is very puzzling to me, and I think it's still puzzling to most of the anesthesia community.
Israel continues to
Okay,
respond.
second topic I want to discuss, the effect of opioids on MAC. And there are many experts in this audience who study this, so I'm in hot water here. The first comment I want to make is that opioids do not change MAC, but they reduce the required end-tidal concentration to achieve a certain probability of no response. So the MAC doesn't change when you give an opioid in addition to an inhaled anesthetic, because the MAC is determined in a state where no other drugs are administered. So the definition of MAC is fixed. You cannot say opioids change in MAC because the definition of MAC requires that you don't give opioids. So you can't change that definition. Cato has done several studies where he looked at the interactions of potent inhaled anesthetic and sevoflurane and other inhaled anesthetics. And on the left, you see the effect of fentanyl on immobility. And these are the sevo concentrations, the fentanyl concentration on the x-axis. And when they looked at probability curves, they noticed that the probability at a concentration of 2 nanograms per ml, which is a concentration that we frequently achieve for because it gives significant anti-nociception without overly suppressing the patient after extubation. So at 2 nanograms per ml, we see that instead of 2% of sevoflurane, in order to achieve 50% immobility, you now need only 1% of sevoflurane. In other words, the curve has shifted in the important range by about 50%. So you need a lot less anesthetic in the presence of a potent opioid. It's even more dramatic when you look at the blunting of adrenergic response. If you want to blunt the adrenergic response in the absence of fentanyl, you need about 4% of SIVO. In the presence of fentanyl, you need about, if you look clearly, 50% probability, about 1%. So you have about 75% reduction in the requirement of the inhaled anesthetic in the presence of fentanyl in order to get BAR. If we look now what is required for our end goals and we choose 1.4% of sevoflurane, you see that immobility is reduced to about 95%, the green dot there, and the bar, blunting of adrenergic response, at these concentrations is about 85%. And that's where I earlier kind of defined an acceptable incidence of movement and hypertension and or tachycardia. So these are MAC curves, but there's only one MAC curve here, and that's this one. The other ones are concentration and response curves. They're not MAC curves. There's only one MAC curve here, and that's the dotted green line. But in the presence of an opioid, you see that the required concentration of the anesthetic is decreased by 15% roughly to generate unconsciousness, or 50% probability of unconsciousness. For immobility, about 50% reduction, and for BAR, about 75% reduction. And if we bring these curves together then we see that if we focus at around 0.7 MAC, we get exactly what is acceptable clinically. I'm going to finish with some discussion on pharmacokinetics of inhaled anesthetics. We all know that the delivered concentration is not the same as inspired concentration, is not the same as end-expired concentration. If this is our kind of old classic anesthesia machine diagram, delivered concentration is what's coming out of the common gas outlet. I'm showing my age now, I know. In the inspired limb, we have the inspired fraction, and here we have the end expired fraction, and this is an error. This should have been end-tidal. Hysteresis. What is hysteresis? There is a time delay between the reaching a certain end-tidal concentration or fraction and the partial pressure in the target tissue, in this case CNS. And when we start the anesthetic, we have an end-tidal concentration that may be at this point a certain fraction of MAC, but in the target tissue, it's still much lower. And when we try to emerge the patient, we see the end-tidal partial pressure fall very quickly when we turn off the anesthetic and increase fresh gas flow. But our CNS partial pressure is still much higher. So there is a time delay in this equilibration. And the hysteresis is simply the time it takes up for the time it takes up for the tissues to fill up with a vapor. And the time constant tau determines that speed. So it's sometimes difficult to explain what time constant is. And I use a very simple example where you have a cup of coffee and you pour some milk in it. And how quickly do you have mainly milk in your cup where the coffee was? Well, it depends on the size of the coffee cup, obviously, and the speed at which you pour in the milk. That's very intuitive. So the time constant is now called volume over flow. If the volume is huge, you have a long time constant. If the flow is very high, you will have a very short constant, and so on. So this allows you to more easily grab the concept behind time constant. And time constant is an exponential, or washing in the agent into the tissues is an exponential process. And it's designed by, or is characterized by these three, the exponential curves, where you have one time where you have one tau, where you have roughly 63% equilibration, 85% and 95% at 3 taus. So it's an exponential process. We look at partial pressure gradients, or it's driven by partial pressure gradients. Classically, time constant is volume divided by flow, but in this case, the time constant has to be changed to the capacity of the organ for the agent, which is the same as the volume of the cup of coffee that you had, and the agent transport into the tissue, which was the same as how fast you pour the milk in. And these two parameters, the capacity and the agent transport, you can actually calculate by looking at the size of the tissue you're interested in and the solubility of vapor in the organ. While the agent transport, you can determine by knowing the organ perfusion of the tissue and the blood solubility. And that allows you to calculate actually the time constant of each tissue in the body. The time constant for the CNS is about 3.3 minutes for isoflurane, 3.5 for sevoflurane, and desflurane 2.6 minutes. So as we all know, desflurane is the faster agent. It's faster in, it's faster out. There is no doubt about that. However, the concept has some limitations because the CNS is not a homogeneous tissue, and also the perfusion is not necessarily equally distributed among this tissue. So it's at best an approximation, but it has been applied first by Ross Kennedy, New Zealand, but also by several companies who have built monitors around this. I'm not going to talk about why lower fresh gas flow because somebody else is going to discuss this. How to use low fresh gas flow. Jan Hendricks and I worked on a big study where we determined the vaporizer setting that was required to maintain end-tidal sevoflurane at 1.3% with a very wide-ranging fresh gas flow with a conventional anesthesia machine, and we started off with 8%. And you see that for the low flow groups, you had to use much higher dial settings, vaporizer dial settings, than for the higher fresh gas flow groups, where the dial setting could be reduced very quickly. One issue with lowering fresh gas flow is that you have a larger standard deviation. This is a group of 0.5 liters per minute fresh gas flow, where at a certain point in time, after 10 minutes, you have a very wide standard deviations on where the vaporizer dial setting has to be in order to achieve 1.3%. While in the high fresh gas flow groups, you don't see that. The reason for that is that, of course, with the high fresh gas flow, your delivered concentrations get closer to the inspired concentration, while for the low fresh gas flow group, the delivered concentration has to be much higher than in the other group, because there is a lot of rebreathing in that under these situations. But you can come up with a curve like this if you group all the data together: fresh gas flow, time, and vaporizer setting. And so it's a three-dimensional surface, and with you can draw several lines through this, and this could all be ways to administer your anesthetic. You could start off with very high fresh gas flow and then change to a lower fresh gas flow after a certain period of time, and then you gradually have to increase your vaporizer dial setting. While in this case, you start off with high fresh gas flow, but you quickly turn the fresh gas flow down, you quickly go to the right, and then you see that your vaporizer dial setting has to be increased a lot. Here is one example of such a regimen. After induction of inhalation induction with sevoflurane with a fresh gas flow of 8 liters per minute, after 2 minutes, the fresh gas flow reduced to 1 liter per minute. An LMA was inserted and the patient breathed spontaneously up. And this is the curve that you see. This is the end-tidal concentration with such a regimen. So you see that you're very close to reaching the desired end-tidal concentration by using parts of the three-dimensional general anesthetic equation curve. You shouldn't have to worry about this part because the brain partial pressure is significantly lower than what you're seeing for end-tidal because of the watch-in time it takes. I'm going to finish here, and there are now computers built into our anesthesia machines that completely automate this whole process of achieving the target end-tidal concentration, achieving the target FiO2, and all this at a very low fresh gas flow, which is very good for the atmosphere, of course. And even the APSF Foundation is now promoting the use of low fresh gas flow. This is a picture was taken in 2004 with Jan Hendricks and Rick Garret at the ASA meeting when we presented one of our abstracts at that time. Thank you for your attention.
We've got maybe 1 minute for questions.